You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about mitral stenosis. We'll go over the epidemiology, the imaging features, grading severity, medical management, and intervention. So let's jump into epidemiology. 60% of mitral stenosis is from rheumatic heart disease. This occurs after an acute rheumatic fever episode, often associated with untreated or inadequately treated streptococcal pharyngitis or strep throat. The mitral valve leaflets become thickened and calcified over time, leading to stenosis. 20% of mitral stenosis is calcific degenerative mitral stenosis, previously known as senile calcific mitral stenosis. 10% of mitral stenosis occurs as part of a congenital condition. Uncommon causes of mitral stenosis include infective endocarditis with valve destruction or vegetations and radiation therapy to the chest in patients who have undergone treatment for cancers such as Hodgkin's lymphoma. Imaging features of rheumatic mitral stenosis. In parasternal short axis, you will see a classic fish mouth appearance due to the fusion of the medial and lateral commissures of the mitral valve, reducing the mitral valve area. There will be restricted mitral valve leaflet motion. In parasternal long axis, you will see distinctive diastolic doming or hockey stick appearance, also referred to as dogleg deformity, of the anterior mitral leaflet caused by commissural fusion. The increase in leaflet thickness begins at the free margins of the mitral valve and progressively extends towards the base. It is also possible for the posterior mitral leaflet to dome, but it is more often immobile. The pathology usually seen on the posterior mitral leaflet is restricted motion. In off-axis parasternal long-axis view, you can see the chordae tendonae shorten, thicken, and become fused together. Chordal abnormalities begin at the points of the leaflet attachment and progressively extend towards the papillary muscles. Parasternal long axis M mode at the mitral valve level should normally have the shape of an X for the anterior leaflet and a W for the posterior leaflet, reflecting rapid emptying of the left atrium into the left ventricle during early diastole, followed by atrial contraction. In M mode through the mitral valve leaflets of rheumatic mitral stenosis, there will be reduced opening of the mitral valve leaflets during diastole with a reduced EF slope of the anterior mitral leaflet, paradoxical motion of the posterior mitral leaflet, and thickened mitral valve leaflets. The E to F slope can also be reduced in poor LV compliance, but if the mitral leaflets are also thickened, then it is probably rheumatic mitral stenosis. Mitral valve area should be measured using 3D planimetry because it is less susceptible to error and compared to 2D and Doppler-based methods. Planimetry must be performed at the mitral valve leaflet tip since the mitral valve domes in diastole. Next, we'll talk about grading severity. Mitral stenosis mean pressure gradient, mitral valve area, and diastolic pressure half-time are measures of mitral stenosis severity. It is much easier to grade mitral stenosis severity than mitral regurgitation severity. Mitral stenosis mean pressure gradient has cutoffs of 5 mm of mercury and 10 mm of mercury for mild versus more moderate versus severe. Mitral valve area of 1.5 cm square or less means severe mitral stenosis, whereas anything not constricted as that means mild or moderate mitral stenosis. The guidelines do not distinguish between mild or moderate in terms of the mitral valve area. They only specify that 1.5 cm square or less of mitral valve area indicates severe mitral stenosis. If the mitral valve area is 1.0 cm square or less, that means very severe mitral stenosis. Diastolic pressure half-time can be used as a supporting parameter, but is not a standalone criteria. Diastolic pressure half-time of at least 150 milliseconds means severe mitral stenosis, whereas anything faster than that suggests mild or moderate mitral stenosis. Pressure half-time is the time interval between the maximum mitral gradient in early diastole and the point where the gradient is half the maximum value, measured in milliseconds. The smaller the mitral stenosis orifice, the longer it takes for the pressure to decline. Imagine if you have two curves, an LA pressure curve, which is like a gentle hill, and the LV pressure curve, which is a tall and transiently dips below the LA curve during diastole. The gap between the two curves is the pressure gradient across the mitral valve. the time it takes to get from the maximal pressure difference, delta P max, to half of that pressure difference, delta P max over 2, is the pressure half time. Over this time, the velocity of the valves decreases from Vmax to Vmax over square root of 2. Since 1 over square root of 2 is 0.7071, we estimate the latter as just 0.7 times Vmax. So another way to think about pressure half time is it is the time it takes for the peak mitral inflow velocity to decrease by 30%. In mitral stenosis, pressure half time more than 150 milliseconds is severe mitral stenosis. Pressure half time less than 150 milliseconds is non-severe mitral stenosis. Just like with the valve area, there is currently no cutoff for distinguishing between moderate and mild mitral stenosis using pressure half time. If the deceleration slope is bimodal, with the decline of mitral flow velocity being more rapid in early diastole than the second part of the E wave, then use the deceleration slope in mid-diastole rather than the deceleration slope in early diastole. If the deceleration slope is concave, then pressure half time cannot be used. If the patient has atrial fibrillation, then avoid mitral flow from short diastoles, use mitral flow from long diastoles, and use the average of several cardiac cycles. If you're unable to directly trace the area of the mitral valve on echo, then you can calculate it from the mitral valve pressure half time or deceleration time. If you're given deceleration time, how do you get pressure half time from that? Just multiply by 0.29. Pressure half time equals 0.29 times deceleration time. Why does this work? Deceleration time and pressure half time each make up the base of the proportional right angle triangles. 1 over square root of 2 equals 0.7071. So the complement of that, 1 minus 0.707, is 0.293. Since the height of the triangle is 0.707, the height of the overall triangle, the height of the small triangle is 0.292, the height of the overall triangle, and the bases are similarly proportional. So the pressure half time is 0.293 at the base of the overall triangle. If this sounds confusing to you, you can access my handouts from my website that will illustrate the difference in these triangles. Now, if you know the pressure half time, how do you get the mitral valve area from that? Just divide it under 220. So mitral valve area equals 220 divided by pressure half time. 220 is in units of milliseconds times centimeters square. Pressure half time is in units of milliseconds. So when you divide that, you get a unit of centimeters square, which gives you mitral valve area. Where did 220 come from? This information was omitted in every textbook I got my hands on. Libanoff and Rodbard in 1966 first noted that patients with severe mitral stenosis had prolonged pressure half times, often above 200 milliseconds. Hadley et al. In 1979 plotted Doppler-derived pressure half times in patients with mitral stenosis, along with cath-measured mitral valve area, and a linear regression found that they had an inverse relationship described by the constant 220 milliseconds times centimeter square, which was partially chosen because they found that a pressure half time of 220 milliseconds corresponded to a valve area of 1.0 centimeters square by catheterization, and they wanted to have 220 divided 220 equals 1.0. Subsequent investigation suggested that the relationship between pressure half time and mitral valve area may be better characterized as an exponential inverse relationship in 1987, but there has not been much in the way of challenging or investigating this area in the interval 3 decades. So we continue to use the empirical linear constant for mitral valve area, 220 divided by pressure half time, instead of using a exponential relationship. Note that in tricuspid stenosis, the tricuspid valve area is described as 190 divided by pressure half time instead of 220 divided by pressure half time that we do for mitral stenosis. What situations invalidate the use of pressure half time to calculate mitral valve area in mitral stenosis, and why? Pressure half time cannot be used in calcific mitral stenosis. It can only be used in rheumatic mitral stenosis, since there's usually coexisting hypertension and ESRD that are likely causing diastolic dysfunction. The equation mitral valve area equals 220 divided by pressure half time assumes normal LV diastolic function. Coexisting aortic regurgitation increases the left ventricular pressure throughout diastole, invalidating the pressure half time equation for the mitral valve area in mitral stenosis. Coexisting mitral regurgitation markedly increases the early diastolic left atrial pressure and underestimates the severity of the mitral stenosis, also invalidating the pressure half-time equation. Of course, coexisting atrial septal defect will cause the left atrial pressures to fall faster than expected, shortening the pressure half-time and overestimating the mitral valve area. Pressure half-time is also inaccurate immediately after balloon valvuloplasty because there is a decrease in the mitral gradient and a reduction in the net LA-LV compliance. The mitral stenosis gradient tends to be higher when heart rate is higher. The pressure half-time should vary inversely with mitral valve area, but also proportionally to the net left atrial and ventricular compliance into the square root of the peak transmitral gradient. Typically, pressure and compliance tend to change in opposite directions, thereby offsetting each other. When there's concomitant and severe aortic regurgitation, the LV diastolic pressures increase from inflow across the mitral valve as well as the aortic valve, thus shortening the pressure half-time, leading to an overestimation of the valve area. When there is significant left ventricular hypertrophy and diastolic dysfunction, LV compliance is reduced, causing LV diastolic pressures to rise faster than in the normal situation, so the pressure half-time is shortened. This overestimates the valve area. The normal peak velocity, peak diastolic velocity of the E wave should be less than 1.3 meters per second. The presence of mitral stenosis results in a high diastolic velocity above 1.5 meters per second. If echo parameters suggest only mild mitral stenosis, but the patient is having significant mitral stenosis-related symptoms, then do exercise stress echocardiography to evaluate the response of the mean mitral gradient in response to exercise to see if that upgrades the patient to moderate or severe. Other imaging. The chest X-ray in patients with abnormal mitral valve will display LA enlargements, whether it is mitral stenosis or mitral regurgitation. The heart is normal in size on chest X-ray except for enlargement of the left atrium, which is even more prominent if atrial fibrillation is possible. Calcification of the mitral valve may be visible. Severe mitral stenosis will also have pulmonary hypertension, which shows up as RV dilation on the chest X-ray. In advanced mitral stenosis, there may be pulmonary vascular redistribution of frank interstitial edema. Now let's talk about medical management of mitral stenosis. What do the 2020 AHA-ACC guidelines on the management of patients with valvular heart disease say? In patients with rheumatic mitral stenosis and 1. AFib, 2. A prior embolic event, or 3. An LA thrombus, anticoagulation with a VKA, a vitamin K antagonist such as warfarin, is indicated. That's a Class 1 recommendation. In patients with rheumatic mitral stenosis and AFib with a rapid ventricular response, heart rate control can be beneficial. Class 2A. In patients with rheumatic mitral stenosis in normal sinus rhythm with symptomatic resting or exertional sinus tachycardia, heart rate control can be beneficial to manage symptoms. Class 2A. Now let's turn to intervention on rheumatic mitral stenosis. Percutaneous balloon mitral commissurotomy, or PBMC, also known as balloon mitral valvuloplasty, or BMV, is a treatment of choice for severe symptomatic mitral stenosis over surgical commissurotomy as long as the valve is mobile, relatively thin, and free of calcium, and there is no left atrial clot or more than mild mitral regurgitation. What is the Wilkins score for PMBC? The 4 components of Wilkins score for percutaneous mitral balloon commissurotomy is mitral valve leaflet mobility, thickness, calcification, and subvalvular thickening. Subvalvular calcifications are not part of the score. Each of these parameters, these 4 parameters, is graded from 1 to 4. You add up the points for a total score between 4 and 16. Scores up to 8 predict good results in terms of reduction of the transvalvular gradients via balloon valvuloplasty. To simplify things, a Wilkins score exceeding 8 out of 16 means it is not suitable to do PMBC. The score needs to be at most 8 out of 16 or lower to do the balloon. So the steps are, you score the leaflet mobility from 1 to 4. 1 means a mobile valve, only leaflet tip restriction. 2 means leaflet mid and base proportions have normal mobility. 3 means the valve continues to move forward in diastole, mainly from the base. 4 means it is immobile or minimally mobile. The valve is immobile or minimally mobile in diastole. So that's leaflet mobility from 1 to 4. Next, you score the leaflet thickening from 1 to 4. 1 is for a leaflet thickness of 4 to 5 millimeters. 2 is mid-leaflets are normal and you have thickening of the margins to 5 to 8 millimeters. 3 is the entire leaflet thickening is 5 to 8 millimeters. 4 is thickening of all leaflet tissue more than 8 to 10 millimeters. Next, you score the leaflet calcification from 1 to 4. Notice these are leaflet calcifications, not subvalvular calcifications. 1 is for a single area of increased echo brightness. 2 is scattered areas of brightness confined to leaflet margins. 3 is brightness extending into mid-portions of the leaflets. And 4 is extensive brightness throughout much of the tissue. Finally, you score the subvalvular thickening from 1 to 4. 1 is minimal thickening just below the mitral valve leaflets. 2 is thickening up to 1/3 of the chordal length. 3 is thickening extending to the distal 1/3 of the chords. And 4 is extensive thickening of all chordal structures. Because the mechanism of successful mitral valvuloplasty is commissural separation, the presence of heavy calcification is an impediment and will lead to lower procedural success and higher incidence of significant consequential mitral regurgitation. Intervening on rheumatic mitral stenosis after calculating the Wilkins score. The presence of significant mitral regurgitation at baseline is a contraindication for balloon valvuloplasty for MS. Why? Because mitral regurgitation tends to increase following balloon valvuloplasty for mitral stenosis. So patients who already have a moderate or greater mitral regurgitation should not undergo PBMC. If moderate or severe MR is present, then you have to treat the mitral stenosis with surgical mitral valve replacement. Mitral balloon valvuloplasty cannot be used in patients who already underwent mitral valve repair. The contraindications to BMBAC for mitral stenosis are as follows: persistent LA or LAA thrombus, obstruction of the IVC, for example by tumor, thrombus, therapeutic ligation, or filter placement, bleeding diathesis, anatomic deformities such as severe kyphoscoliosis, previous pneumonectomy resulting in severe irritation of the heart, more than moderate MR, massive or bicommissural calcification, severe concomitant aortic valve disease, severe organic tricuspid stenosis or severe functional tricuspid regurgitation with enlarged annulus, severe concomitant CAD requiring bypass surgery. These are the contraindications to PBMC for mitral stenosis. PBMC for mitral stenosis can be performed safely during pregnancy with minimal use of radiation and appropriate shielding. What do the 2020 valve disease guidelines say about management of symptomatic severe rheumatic mitral stenosis? Well, in symptomatic patients, meaning NIHA class 2, 3, or 4, with severe rheumatic mitral stenosis, mitral valve area of 1.5 centimeters or less, stage D valve disease, and favorable valve morphology with less than moderate 2+ MR in the absence of LA thrombus, PMBC is recommended if it can be performed at a comprehensive valve center. That's a class 1 recommendation. In severe symptomatic patients, NIHA class 3 or 4 with severe rheumatic mitral stenosis, mitral valve area of 1.5 centimeters square or less, stage D, who are 1. Not candidates for PMBC, 2. Have failed a previous PMBC, 3. Require other cardiac procedures, or 4. Do not have access to PMBC, mitral valve surgery such as repair, commissurotomy, or valve replacement is indicated. That's a class 1 recommendation. In symptomatic patients, NIHA class 2, 3, or 4, with rheumatic mitral stenosis and a mitral valve area more than 1.5 centimeters square, if there is evidence of hemodynamically significant rheumatic disease on the basis of a pulmonary artery wedge pressure of more than 25 millimeters of mercury or a mean mitral valve gradient of more than 15 during exercise, PMBC can be considered if it can be performed at a comprehensive valve center, class 2B. In severely symptomatic patients, NIHA class 3 or 4 with severe rheumatic MS, mitral valve area of 1.5 centimeters square or less, who have suboptimal valve anatomy and who are not candidates for surgery or who are at high risk of surgery, PMBC may be considered if it can be performed at a comprehensive valve center, class 2B. Now, what do they say about management of asymptomatic severe rheumatic MS? In asymptomatic patients with severe rheumatic MS, mitral valve area of 1.5 centimeters square or less, stage C, and favorable valve morphology with less than 2+ MR in the absence of LA thrombus, who have elevated pulmonary pressures, meaning pulmonary artery pressure, systolic pressure of more than 50 millimeters of mercury. PMBC is reasonable if it can be performed at a comprehensive valve center. That's Class 2A recommendation. In asymptomatic patients with severe rheumatic MS, mitral valve area of 1.5 centimeters square or less, and favorable valve morphology with less than 2 plus MR in the absence of LA thrombus who have a new onset of AFib, PMBC may be considered if it can be performed at a comprehensive valve center. That's a Class 2A recommendation. Now, let's end with talking about intervention on non-rheumatic mitral stenosis, previously called senile calcific mitral stenosis. Intervention in this group should be delayed until symptoms are severely limiting and cannot be managed with diuretics and heart rate control because of several features that make non-rheumatic, i.e. senile calcific mitral stenosis much harder to intervene on compared to rheumatic mitral stenosis. First, because calcification involves the annulus and base of the leaflets without commissural fusion, you can't do percutaneous mitral balloon or surgical commissurotomy. Second, the presence of severe MAC can be quite challenging for the surgeon because it causes problems in securely attaching the prosthetic valve and narrowing of the valve. Supraannular insertion and other innovative techniques can be used, such as placement of a felt patch around the valve orifice to anchor the prosthesis. However, this only works if the mitral orifice is adequate. If the annular calcification narrows the orifice, it may have to be debrided. The other alternative is left atrial to ventricular bypass with a valve conduit in extreme cases of calcification, both of the leaflet and the annulus. Finally, patients with calcification are often elderly and debilitated, have multiple comorbidities, and are at high risk for surgery. The 2020 Valve Disease Guidelines offer one recommendation about non-rheumatic MS. In severely symptomatic patients, New York Heart Association 3 or 4 with severe MS, mitral valve area of 1.5 centimeters square or less, stage D, attributable to extensive mitral annular calcification, valve intervention may be considered only after discussion of the high procedural risk and the individual patient's preferences and values. That's a Class 2B recommendation. Congratulations, you got through this long episode on mitral stenosis.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.